Imagine a 61-year-old woman who was referred to a chronic pain psychiatry clinic, a clinic in which individuals with chronic pain but also mental health concerns be evaluated for both co-occurring or coexisting problems. She was actually referred by her primary care physician. And the reason or the chief complaint was for psychosis. In other words, hearing voices. The patient came with a past medical history of endometriosis, mild degenerative joint disease, chronic pain syndrome in so many words, that included dysmenorrhea or irregular menstrual cycles, migraines, sciatic pain, that's nerve pain traveling down the leg, and musculoskeletal pain. At this point, immediately might generate some questions. Good point to reflect. What could be occurring right away based on the past medical history, age, and other features that were already shared? It asks the question or begs the question, what else do you want to know? What else do you want to do in terms of evaluations, tests, exams, laboratory analysis, etc.? And where is your mind going when it comes to considering what could be causing this presentation, this set of symptoms, so-called differential diagnosis, as well as what are the therapeutics, treatments that you might be considering? But we'll advance the story to see what else unfolds. Turns out from the history of present illness, or HPI, that for about 4 months, the patient has had a new onset psychosis. So this is not something that has been going on in most of her life in the context of recurrent opioid withdrawal, meaning she's going through the after effects of stopping her opioid, complicated by intermittent delirium. Delirium is confusion or medical confusion. So you have a lot to unpack there. You have a new or brand new set of symptoms in the context of some med changes, important ones. And so you have a few hints there as to what could be going on. Turns out that psychosis is not typically something that presents at that age for the first time. Usually presents in younger age. Psychosis, as in schizophrenia or schizoaffective disorder or delusional disorders, those typically affect individuals starting in the ages of late teens or 20s. Turns out that the patient was running out of her opioid early for about 4 months. So she was running out of the medication and was treating her withdrawal from running out with over-the-counter Benadryl. And this was contributing to confusion and psychosis. We know that Benadryl or diphenhydramine, which is an antihistamine, can cause confusion, particularly when you're a bit older. So that plus running out of her opioid was contributing to this confusion and so-called psychosis. She was never combative or agitated throughout this, never had safety concerns like suicidal ideation or homicidal ideation, thankfully. However, there were other psychiatric symptoms of note. So this psychosis was characterized as having three parts: visual hallucinations, delusions, and auditory hallucinations. The visual hallucinations, for example, included abnormal experiences of streetlights. These would resolve rapidly within days. And so this was the least distressing or problematic of the symptoms. She did have delusions or fixed false beliefs about her neighbors conspiring against her, bugging her place, and broadcasting thoughts to her. In other words, some paranoia. This did not resolve immediately and actually required some treatment. This persisted despite the visual hallucinations going away quickly. Auditory hallucinations were characterized as negative commentary or chatter from male and female voices, maybe the neighbors, but also some strangers. And there were some condemnatory religious themes, meaning some very harsh, critical themes and religious sort of guilt themes. This also did not resolve immediately and required treatment. You had some lingering effects despite some of these symptoms disappearing. All of these, or each of these, were characterized as ego dystonic. That's fancy speak in psychiatry for symptoms that are really distressing and bothersome. There are individuals who have hallucinations and delusions and that are not bothered by these, or that do see them as consistent with reality. She understood that this was not her reality, her usual state of mind, and that something was wrong. She found it extremely distressing and uncomfortable and wanted it treated. So, with all the information that's been shared, this is another good stopping point to reflect. What else do you want to know at this point? What other information might be useful to disentangle what's been going on? What else do you want to do in terms of tests, analyses, interviews, physical exams? And again, where is your mind taking you in terms of your differential diagnosis, your treatment considerations, and such? I'll advance further. The primary care physician actually ordered a number of labs when she started to present with these symptoms. And the workup included labs like complete blood cell count, complete metabolic panel, thyroid stimulating hormone, vitamin levels like B12 and folic acid or folate, and a CAT scan of the head. All of these were found to be within normal limits, so negative. They were normal. There were also no significant physical exam findings. She had no constitutional symptoms that she reported, meaning like malaise, fatigue. She had no weight loss. So that was a negative exam as well. In terms of treatment, for about 2 months, the primary care doctor actually resumed Percocet, which is an oxycodone acetaminophen opioid, to prevent withdrawal. Tried to resume opioids to offset that. Also started a medication known as Seroquel or quetiapine, 25 milligrams at bedtime, and increased it to 50 milligrams. This is an antipsychotic, actually, that can be helpful in states of confusion or in psychosis. Additionally, started some Zoloft or sertraline and SSRI or conventional antidepressant, 50 milligrams daily, and increased that to 75 milligrams. These were the efforts by the primary care physician to offset some of the symptoms that he was observing in his patient. The effects included that the delusions or the paranoia improved, but had persistent auditory hallucinations. Alongside the concern for over this chronic opioid use, this all led to the referral to the chronic pain psych clinic. So instead of referring to just conventional psychiatry or conventional pain management, felt that it was valuable to refer to a clinic that can handle both issues, given that there were chronic opioids in the mix as well as now psychiatric symptoms. On exam by myself and psychiatry team, found that the patient was, in terms of appearance, in no apparent distress, so was not overwhelmed or distressed, was age appearing, matched her age, well nourished, well groomed, so she was taking care of herself, eating well. Her behavior was pleasant, she was cooperative, she was a bit fidgety, and her mood was described by her as depressed. Her affect, meaning how she looked physically in her face, was full range, meaning that she was appropriately changing how her face would match her mood depending on what she was talking about. In this case, it was incongruent. It did not match what she was stating as this persistent sadness or depression. She would smile at times, and that didn't make entire sense, if you will. Her eye contact was within normal limits. Her speech was of normal rate and rhythm. Her thoughts were linear, meaning that they were normal, goal-oriented, and organized. Her thought content lacked any suicidal ideation, homicidal ideation. It also lacked delusions and paranoia, so thankfully that had gotten better. Her perception, meaning how she perceives the world, did include those auditory hallucinations I mentioned. In terms of her sensorium or how aware or alert she was awake and alert as well as oriented times 4, meaning oriented to self, oriented to place, to time, and to context. So she was quite intact in this sense. Her insight and judgment were also very good. Insight is a measure of how aware you are of what's going on with you, and judgment is also what kind of behavioral choices you might be employing. They were both good. And her motor exam, meaning how her body was sort of moving, lacked any major findings. It was within normal limits. So, to summarize the presenting symptoms, she had the auditory hallucinations, depressed mood, insomnia, both at the beginning and during the night. So, that's onset and maintenance insomnia, respectively. She felt fatigued, had reduced appetite, was also socially withdrawing, and also had some amount of guilt secondary to smoking cigarettes. She had some difficulty with concentration and focus, as well as anxiety over her auditory hallucinations. They were ego dystonic again and distressing. I've shared a lot of information thus far. This is another good stopping point to reflect. One might ask, as a clinician, what else do you want to know at this point? What else do you want to elucidate? What else do you want to do in terms of, again, tests, analyses, interview questions, treatments, and where is your mind going in terms of what's causing all of this? It's important to stop, reflect, stop, reflect, stop, reflect repeatedly so that we can really promote the best individualized care for the patient in front of us. To advance the case a little bit more, we learned that she had a chronic pain as well as psychiatric history. In terms of chronic pain, her history included endometriosis, mild degenerative joint disease, chronic pain syndrome. I mentioned these earlier. She had chronic opioid history that actually amounted to 50 years. It's a very long time, 5 decades. Started at age 12, so she was quite young, for dysmenorrhea, so abnormal menstrual cycles at the time of puberty. This is a very unusual trajectory, very young age, and yet she was placed on opioids then and never quite discontinued off of them. Her most recent dose from a primary care physician included Percocet, again, oxycodone slash acetaminophen, 5 to 10 milligrams every 4 to 6 hours as needed for any musculoskeletal pain that she experienced. And remember, she was on that, but she was running out early for about 4 months. So she may have developed some kind of dependence and needed more of that agent. Also, she was taking gabapentin, 900 milligrams 3 times a day. That is an antiepileptic that is used for neuropathic pain. And rarely she would get some articular injections, meaning injections in the joints for her pain. In terms of past psychiatric history, she really had none formally at least. She had no medication trials with antidepressants and other meds. She had no inpatient or outpatient psychiatric care and no suicide attempts. Her family psychiatric history did include a history of a mother who had alcohol use disorder, ETOH use disorder. Patient herself had a substance use history of remote alcohol use disorder that had been in full and sustained remission. So at some point, she also struggled with controlling her alcohol intake. She also, as mentioned earlier, smoked regularly. She smoked about a pack a day for those same 50 years. She did share that she had a trauma history. She had childhood physical as well as emotional abuse. Physical trauma did not result in any major injuries. She just described her parents as quite strict. She also had some emotional abuse in terms of that strict parenting, but denied having to relive or re-experience the symptoms and no hypervigilance that she was aware of. So in other words, she was not revisiting those moments in traumatic reminders like flashbacks or nightmares, nor was she on, to her knowledge, on pins and needles, scared of anything that resembled her earlier trauma. In terms of her social history and developmental history, she completed high school and had numerous clerical jobs for decades, then went on disability for chronic pain at some point. She was married and did describe her partner to be somewhat doting, meaning someone who would sort of take care of everything for her, arguably even enabling, but no children. And they were financially stable, so they had no major stressors when it came to money or the law or anything of the sort. So at this point, once again, encouraging reflection and integration of all the information, you might ask, what else do you want to know? What else do you want to do in terms of interview, test, physical exam, analyses, and where is your mind as a clinician going in thinking about the differential diagnosis or possible treatment directions? I'll share that In terms of psychopharmacologic treatment or medication treatment, we basically made the decision when we met her, integrating all of this, that we might want to rotate her antipsychotic medication. She was having persistent psychotic symptoms. She was not delirious. She was not encephalopathic or confused. This no longer looked like it was just due to withdrawal and Benadryl. This was a lasting symptom that was not better explained by her Benadryl use, since she had curb that. So we decided to switch over from quetiapine or Seroquel over to Zyprexa, also known as olanzapine, and started 2.5 milligrams at night, twice a day, and 15 milligrams at night. Now, this was gradually increased over time, and this was titrated or increased every 2 to 4 weeks for up to 27.5 milligrams total. And this finally did have a significant reduction in her anxiety and auditory hallucinations. The rationale for choosing this medication was based on a study that I had performed, a systematic review that is shown in the box below, where we had reviewed the role of atypical antipsychotics in chronic pain. In other words, second generation antipsychotics. Now, there is no suggestion here that these antipsychotics are meant to treat pain, but we wanted to choose the one that did have some possible role in musculoskeletal pain, migraines, fibromyalgia. And for those who are interested in this topic, they can visit the systematic review and the article that dives into greater detail. We also felt that it was important to continue to increase the sertraline or Zoloft, which was an SSRI antidepressant. It is indicated for both treatment of depression but also anxiety. And so we increased that to 100 milligrams. We introduced a different agent known as Atarax or hydroxyzine, which is a cousin of Benadryl. It is also an antihistamine, in order to help with anxiety. And so she was instructed to use 25 milligrams 3 times a day, or TID, as needed, and to avoid Benadryl. This is a less deliriogenic or confusion-prone medication than Benadryl. We also went ahead and looked at how to manage the opioid in the midst of all of this. Remember, this is somebody who's for 5 decades on chronic opioids, and as a result of that, was starting to rely on it more frequently, was not doing well with it, and needed to, was running out early and going into withdrawal. So we decided actually to change the short-acting opioid to a long-acting opioid. The short-acting opioid was Percocet every 6 hours. We changed it to Cadian, or morphine extended release, 30 milligrams daily. So it's roughly, a morphine equivalent, to where we reduced it to about 30, but that's a 24-hour extended release version of morphine. And this led to a wean over time, a reduction, a detox, if you will, over time, where we had Cadian 30 milligrams per day for 1 week, then down to 20 milligrams per day for 3 weeks, then 10 milligrams per day for another 3 weeks, and then finally stopped. And of course, we followed her closely during this process so that we can assist with any symptoms, discomfort, etc. That's an image of what the Cadian paperwork looks like. We also introduced a couple of other agents to help with pain and with mood. Cymbalta, or duloxetine, which is an SNRI and has some impact in musculoskeletal pain and neuropathy, was introduced, and it was increased to 60 milligrams a day. And diclofenac, an anti-inflammatory, was introduced as well to assist with her arthritis and her musculoskeletal pain. She was also sent to physical therapy within our division, within our department, and did physical therapy 1 to 2 times a week for about 12 weeks to help complement what we were doing with pharmacology. In addition to that, sort of as a perfect, biopsychosocial model of care, we included cognitive behavioral therapy, or CBT. And with cognitive behavioral therapy, we were trying to invite her to reflect more on some of the stressors that came about with her chronic pain, and also social stressors that she carried about from her trauma. The focus was self-critical cognitive distortions that we started to identify early on, meaning that she had the propensity to have certain thoughts that were very negative about herself, and we thought that they were not very productive, that they were distortions, and they weren't helping really with everything that she was experiencing. She tended to have rejection sensitivities, meaning that she was prone to being very injured by others not accepting her. She had a lack of assertiveness about her. She would not assert her needs. She had body image issues as well, and possibly some alexithymia. It was very difficult for her to name her emotions. Alexithymia is Greek for lack of words for mood. And so sometimes she just couldn't access her feelings and describe them in appropriate ways. And CBT was meant to assist her with this. This was done on a weekly basis. We also included nicotine replacement therapy. So that's where she was able to reduce her nicotine down from 15 cigarettes per day down to 5 cigarettes per day with the use of Nicoderm patches and other coping strategies. And while the CBT and the nicotine replacement therapy was started while on Zyprexa 27.5 milligrams, which is a very high amount. We are aware of how that can come with various side effects and metabolic burdens. She did have actually some weight gain, which wasn't all bad. She came in actually rather thin and underweight, and she did have some CBT anxiety reduction. So we were able to reduce her Zyprexa or olanzapine from 27.5 all the way to 5 milligrams, but her auditory hallucinations returned. And we found the sweet spot finally at 7.5 milligrams a day. So we were able to stabilize things. If you think about that dose, olanzapine 7.5 milligrams a day, that really isn't a typical dose for conventional or typical psychiatric disorders with psychosis, like schizophrenia or schizoaffective disorder. So this was an unusual case in which 7.5 milligrams, with some other strategies, of course, took care of the psychosis, but it's probably because we weren't dealing with a primary schizophrenia. So what was the outcome? At 12 months, the patient was euthymic, meaning that she had good, normal mood without psychosis, was socially active, and doing well. Her pain was well controlled with no resumption of opioids, and she had no cravings for them. So this was arguably a win, and we were very pleased, and so was she, with the outcome of this. We actually published this case, we as in myself and a colleague, in the Journal of Psychiatric Practice, titled Case Report, De Novo and Persistent Psychosis After Withdrawal from Chronic Opioid Therapy. Though it's a very unusual case, if somebody wants to read it in greater detail, they can, of course, read the article. But it was a very important case to present, to the literature, because number one, it was an unusual case of somebody on opioids from a very early age. It was also an unusual case of a mixed picture of delirium and psychosis in the context of stopping those opioids. Additionally, it was very interesting case that sort of illustrated how biopsychosocial care can be conducted with a mix of medication adjustments, opioid weans, psychotherapy, physical therapy, and substance use care in terms of nicotine replacement therapy. All of these things working in concert to help an individual with a complex presentation. This is the timeline of the case that I just presented, how it all sort of occurred. You see, at the beginning, 50 years of chronic opioids, a 4-month period of overuse / withdrawal cycle mixed with not just opioids and withdrawal, but also diphenhydramine or Benadryl over the counter, which was causing delirium and confusion. You had the psychosis onset. You had delusions, this bar here, that lasted up until a certain point, and visual hallucinations, which were very transient, but the auditory hallucinations were the longest of the psychotic symptoms that resumed, or that persisted, excuse me. Here you have opioid resumption and psychopharmacologic titration that we just reviewed. We weaned off of the opioid over time, took about 2 months, and then we down titrated or reduced olanzapine. So initially we really relied heavily on olanzapine, but then we decreased it, and then achieved maintenance cyclopharm in terms of the final regimen. And again, her symptoms disappeared eventually. So it took a while. And the other thing that's important from this image to take home is that something that has been going on for 50 years or longer is clearly not going to take a week or two to address. Something that has been treated with high dose opioids for a long time and then altered is not going to be fixed rather, simplistically with one or two interventions. It's going to take time. It's going to take individualized care. It's going to take biopsychosocial interventions. So it's a good image to remind us that there are no shortcuts in this kind of care. This is a reminder of the various things that could have been at play in this case in terms of the differential diagnoses, the different conditions to consider, included a primary psychotic process underneath these chronic opioids. What if, for instance, she had all along a chronic primary schizophrenia, delusional disorder, something of that sort, but it was masked or indirectly even treated by the opioids? If you think of opioids as CNS or central nervous system suppressants, they can reduce anxiety, they can sometimes blunt some of those effects that are coming from the brain. So who knows? She could have already had a chronic psychiatric disorder that was just masked, if you will, or covered up by the opioid. Maybe she had obsessive compulsive disorder or OCD with some ego dystonic or unpleasant features. Maybe this could have been complex post-traumatic stress disorder with personality disorder and so-called micropsychosis. These are jargon terms from psychiatry where somebody with complex trauma might have changes in their identity, personality, and then as a result of that also be prone, especially under stress, to experience brief psychotic breaks from reality, such as delusions, paranoia, etc. Maybe she had major depressive disorder or depression with psychotic features. There are variants of major depressive disorder that include psychotic features. It could have been an atypical delirium. So an atypical delirium would be again a medical confusion or encephalopathy secondary to medication effects, other medical matters, and of course there could have been other considerations here. But it is a rich case that illustrates that we must be thinking about all of these possibilities and holding them simultaneously in our heads as clinicians. In terms of literature on this topic, there's actually very little out there. There's very few or sparse examples of opioid withdrawal, quote unquote, psychosis. In fact, what is described more often is a delirium, if you will, or encephalopathy, where somebody might have very transient, temporary, reversible psychotic symptoms. And it's really confounded or complicated by the possibility that this is actually more so confusion, temporary brain disruption from medication changes, not exactly the same as psychosis. Our case really stood out because after controlling for attention and orientation, we did feel strongly that this was no longer a delirium and the person had, for weeks, if not months, persistent psychotic symptoms. So this did stand out from what most of the literature talks about when it comes to opioid withdrawal. And again, these are very rare reports. This raises the question as to what was going on here. What could be the mechanism of action of this? How does this occur? Now, one theory is that, again, maybe opioids as central nervous system suppressants, meaning things that calm the central nervous system, were blunted, basically simply reduce distress, anxiety, and even psychosis. In other words, if you have strong opioids on board, maybe you're just sort of blunting again the brain so that one doesn't feel anxiety, distress, psychosis. I do see this clinically regularly where individuals tend to feel like their psychiatric symptoms do improve as a result of opioids. Now, of course, there are other side effects and other problems with that. So it's not meant to suggest that we should be giving opioids for those conditions, but I have seen that before. Another theory is that maybe the kappa opioid receptor is being involved or implicated. So the kappa opioid receptor is one that is rarely discussed in medicine. So when we think of opioids and where they work in the brain, they work on mu receptors. These receptors are all named after Greek letters. And so the mu receptor is really usually the one that it gets the most attention because that's where opioids work and activate and they touch up on that little mu receptor and that causes analgesia, in other words, reduction of pain. But opioids actually affect many different receptors, as most of our meds do. And kappa receptors are a different opioid receptor that are important to consider. When you involve the kappa receptor, it can be what's called psychotomimetic. That's a long word for saying it can induce psychosis. It can induce psychotic symptoms, which is very interesting. And so the chronic use of K receptor agonists, meaning meds or opioids that activate the K receptor, can lead to dopamine receptor upregulation in the mesolimbic and nigrostriatal pathways. That's a long way of saying that if we use opioids for a very long time and they activate the kappa receptor, you can get more dopamine in the brain pathways that can themselves contribute to psychosis. And so this is one possible pathway or one mechanism that could be involved. The table that I'm showing here actually shows how through certain experiments we've shown that kappa opioid receptor agonism, meaning again activation of the kappa opioid receptor, can be blocked with opioid antagonists. So in other words, we can prevent psychotic effects if we block that receptor, and like that we learn that these receptors, these kappa opioid receptors, really are involved in kappa-induced psychotic effects. And naloxone, which you hear a lot about, and naltrexone as well, are blockers of these receptors, and they can prevent these kappa opioid receptor agonists from causing psychosis. This image is also from the article that we published on this case that I just presented, and it's basically taking a stab at what the mechanism is here. This is by no means, etched in sand. This is, or etched in stone, excuse me. This is basically a potential mechanism as to why this specific individual might have had, psychotic effects or psychotic symptoms way after many years of taking chronic opioids. So obviously, there's the long-term opioid use in the middle here, but remember, long-term opioid use mixed with certain risk factors is really what's most important. So somebody might have had psychiatric or psychosocial risk factors or genetic loading or diathesis. Diathesis is a fancy word for risk. And so somebody might have been loaded with certain risk factors. Remember, her history included trauma and included genetic history of maternal alcohol use disorder. So there may have been something already there that then, with the mix of long-term opioid use, might have led to psychotic disorder via these smaller arrows. So you can see each one has smaller header numbers. These are all references in our article that are meant to offer support for these theories. But one we talked about was chronic kappa opioid receptor activation. I just referred to that in the previous slide. This can lead to mesolimbic or midbrain to limbic area dopamine release, DA being dopamine. You can also have some other changes over time in terms of neuron maturation. Oligodendrocytes are a type of neuron in our brain, as well as abnormal myelination and pruning. So these are complex processes that are part of neurodevelopment, how our brains develop. And during adolescence, particularly when somebody so young as her, age 12, was exposed to high dose opioids, you might presume that that had an impact actually on brain pathways to the point of maybe impacting her risk for psychotic disorder. Now, all of these things in concert, of course, and maybe even other factors contributed to this picture.